Hi, this is Yuko, and welcome to lecture number 7. Let's discuss trauma and stress-related disorders. So stress and trauma, everybody has experienced some form of stress and perhaps even some sort of traumatic life event or life stressors. So oftentimes the characteristics of the experience are extraordinary in intensity or the severity. But remember again, this is going to be dependent upon the individual's perception. All right. So the stresses are things that extend beyond the stress of everyday life. So individual stressors, examples would be abuse, physical illness, group trauma or stress, things like a terrorist attack, natural disaster, or war. So the characteristics of stress and trauma, most of us are able to work through the experience and go back to our usual method of coping, but sometimes it interferes with our ability to effectively cope. And we may develop things like an adjustment disorder, a stress disorder, post-traumatic stress disorder, or dissociative disorder. So what happens with PTSD? There's a disturbing pattern of behavior that is demonstrated by the individual who has been witness or has experienced something that they felt was very, very traumatic to them. Their responses are intense fear, a feeling of hopelessness, also helplessness, terror. They oftentimes re-experience the trauma either through their dreams or they get intrusive recurrent thoughts. They can also have flashbacks. All right. So then what they do is they begin to do avoidance of situations that are similar in nature to what they previously experienced. And oftentimes they start to have very negative thoughts. Okay. They're constantly on guard or they're hyper aroused. Related disorders, adjustment disorder, that's a reaction that causes problems for the individual. Usually it develops within a month, but doesn't last any longer than 6 months. Acute stress disorders, where they keep re-experiencing and have avoidance and hyperarousal. It occurs from 3 days to 4 weeks after the trauma, but it can be a precursor to PTSD and keep occurring. Reactive attachment disorder or disinhibited social engagement disorder usually occur before the age of 5 years old. So the etiology of PTSD has to be a causative trauma associated with an event, exposure rather than personal characteristics. That means rather than the individual being somebody who may not have a high level of resiliency and not be able to cope with certain types of stressors, as opposed to the fact that they were exposed to something that was extremely traumatic in their perception. They may lack social support. They may have peri-trauma disassociation where they feel like they've stepped out of their body and they're having basically an out-of-body experience. They may have had a previous psychiatric history or personality factors that will increase the risk, such as being overly sensitive. Cultural considerations, it's universal. Um, in countries where there's a lot of political problems, oftentimes people have PTSD from the outcomes, such as things like wars, bombings, and so forth. Individuals who have a stronger sense of self and a stronger cultural identity are less frequently diagnosed with PTSD and have better long-term outcomes. So what can we do? We can put them on counseling. We can give them medications. We can do what's called CBT, which is cognitive behavioral therapy, which is basically what we do now, which is bringing the patient out of the past and out of the future and bringing them to the here and now and having them live their life now in the moment. And we demonstrate to them how their thoughts affects their behavior, how their behaviors affect their thoughts. Okay, we can do exposure therapy. There, the jury is out on that. Sometimes it's helpful, sometimes it's not. We can do relaxation techniques, adaptive disclosure, community-based care, and most certainly mental health promotion. All right, so dissociative identity disorder, the subconscious, that's their defense mechanism to prevent them from reliving the trauma. Okay, it can occur before, or I'm sorry, during or after, becomes easier with repeated use. Oftentimes, again, the individual feels like they're watching themselves on a stage. All right, so it interferes with relationships, their ability to function, their ability to cope. Three main types of dissociative identity disorders: amnesia, DID, used to be known as multiple personality disorder, and depersonalization or derealization. Okay, so what can we do? Individual therapy, group therapy, and also medications for anxiety or depression. So what are our goals? Improve their quality of life and improve their functional ability so that they can become productive and they can feel that they have control over their life. We need to assist them to be able to get control over the symptoms, not have the symptoms control them. All right, so we want oftentimes to be able to restore the individual, but not in every case, especially cases of abuse or trauma. All right, we want to take a look at their motor behavior. What's their appearance like? What is their affect like? Are they flat? Are they guarded, suspicious? Are they restricted? Are they hyper alert? Do they have discomfort with any type of physical closeness? Or can you clearly see that they're agitated or anxious? Are they having problems with relationships, specifically those of authority? All right. Difficulty sleeping, change in appetite, and self-medication, behaviors like drug and alcohol use. So their mood can range from angry to hostile. They can experience the nightmares, the flashbacks, self-destructive thoughts, fantasies, hallucinations, intrusive thoughts. What we want to do is get them back to reality, and we want to help them to fill in the memory gaps in some cases, and we want to be able to reduce their thoughts of ideas of self-harm. Well, this one didn't turn out very well, did it? Judgment and insight. We want to help them to see the relationship between the trauma and their symptoms. All right, we want to help them to be able to make better decisions. And their self-concept, we want to build their self-concept so they don't have low self-esteem and they don't see themselves as being worthless. So the outcomes, definitely, always physical safety. We want to be able to have them recognize when they feel like they're going to harm themselves and have something or someone to be able to intervene to assist them. We want them to demonstrate healthy coping mechanisms, have a healthy support system, and do non-destructive emotions. All right. So what do? Help them with grounding techniques, bring them to the here and now, encourage them to journal, use distractions like television, music, art therapy, exercise, and have them think of themselves as being a survivor rather than a victim. All right, so grounding, helpful with dissociation, increases their contact with reality, and again, brings the patient to the here and now. So, all right, hold on, and I will change slides for the next lecture. All right, let's take a look at obsessive compulsive disorders. So here's your lecture objectives. So obsessions are the recurrent, persistent, intrusive, and unwanted thoughts. Okay? The compulsions are the behaviors that the individual engages in, not necessarily out of pleasure, but in an attempt to neutralize anxiety. The problem is, once they engage in the compulsions, their anxiety dissipates, but then begins to build back up again because now they're getting anxious about the next time they have to perform the compulsion. All right. And it rises and it peaks and then they have to go engage in the behaviors again to neutralize the anxiety. So you can see that OCD can become very, very debilitating. All right. So it's diagnosed once the thoughts or behaviors consume the person where it interferes with their ability to function socially and occupationally. All right. The person realizes that oftentimes the thoughts and behaviors are unreasonable, but they can't do anything to stop them. So what are some of them that they do? Checking doors, right? Closets, under the bed, counting things on their fingers, on their teeth, washing and scrubbing, praying and chanting, touching, rubbing, tapping, ordering, rearranging, being very, very rigid in their performance and being aggressive. So it can start in early childhood. In females, it's more commonly going to begin in the 20s. So they will have periods of time when it gets better and gets worse. All right, self-soothing behaviors that they can do, like the skin picking, trichotillomania, where they pull out their hair. A lot of times when they do the trichotillomania, they will also eat their hair, okay? And then the onchophagia is where they do the nail biting. BDD, body dysmorphic disorder. When we get to the eating disorders in lecture number 8, we'll talk more about body dysmorphic disorder. Hoarders, believe it or not, hoarders are actually obsessive compulsive. Reward-seeking behaviors, the kleptomania where they steal, and oniomania, compulsive buying. To me, it sounds like they go out and buy a lot of onions. So what can we do to help them? Aaron Beck said that there is an approach to the emotional disorders that focuses on the childhood and environmental experiences of the individual growing up. However, in short-term hospitalization, which is approximately 72 hours, there's not enough time to do that. So oftentimes that individual has to go into some sort of private psychotherapy that's usually going to be long-term. It can be heredity as well. Culturally, we know that highly religious individuals, both Christian and Muslim, have a heightened sense of personal guilt. In some cultures, there's a belief that you're doing what you're doing as far as OCD goes because there's a supernatural force that's causing you to do it. All right, so we can give medications, usually to medicate the depression and the anxiety for it. All right, so we can give the SSRIs, SNRIs. All right, for treatment-resistant OCD, second-gen antipsychotics, the atypicals. Okay, but remember that with risperidone, we need to be real careful because of gynecomastia and because of prolactin increase. We can do behavioral therapy, which is exposure, where we confront the situation and the stimuli that the patient usually tries to avoid, or response prevention, where we focus on delaying or avoiding performing the rituals and helping the individual to tolerate the thoughts and anxiety. However, the problem with this is that in delaying or avoiding the rituals, oftentimes it just really heightens the individual's anxiety level, and it's almost impossible for them to abstain. So what can we do? There's a what's called YBOCS, YBOCS, which measures obsession compulsion. We go by history. What do they look like? Are they tense? Are they anxious? What's their mood and affect? What's their thought processes? All right, how's their judgment and insight? Self-concept and so forth. Are they having problems sleeping? Are they able to sleep because they're so involved in doing their behaviors? Or an example of that would be somebody who has to check the front door, goes to bed, and lays there and thinks, did I check the front door right? It gets back up and goes and checks the front door. It goes back to bed, lays there and thinks, oh no, did I lock the deadbolt? So that can keep them up, needless to say, all night. Or they may have number of times they have to go back and check things, like number 13 or 17 or 7 times and so forth. So we want to teach them therapeutic communication, relaxation techniques, behavioral techniques, and family education. That's probably one of the most important things. All right. Teach them about OCD and about openly talking and behavioral techniques to be able to reduce their engagement in those compulsions and what to do when the intrusive thoughts come into their head. A good example of an intrusive thought would be, let's say you're driving to campus one day and a song comes on and you get the song in your head and you can't get it out of your head. That's the way an intrusive thought would be. All right. Teach the families to avoid giving advice and trying to fix the problem. Tell them, please be patient, all right? And to make sure that they take a break so that there isn't any type of friction that is going to further escalate the anxiety level of the client. All right? All righty, hold on and we'll go to the next one. All right, let's talk about cognitive disorders. One of my favorites. Here's your lecture objectives. So we're going to talk about delirium, dementia, amnesia, and cognitive disorder not otherwise specified, or NOS. All right, so cognitive processes, the way our brain thinks, right, has a direct relationship to our ability to perform our ADLs, or activities of daily living. They're intellectual and they are perceptual, okay? They are integrated not only with our emotional values, but also spiritual. It becomes an issue when the individual can no longer understand the facts or connect the appropriate feelings to events, and they have trouble responding to the complexity of life's challenges. So let's talk about delirium first. It's present in about 60% of nursing home residents who are 75 or older. Approximately 80% of people with terminal illness will develop delirium prior to death. Delirium always exists secondary to another medical condition. It occurs more often in older adults, and the most causative factor in older adults are UTIs. Okay, it can also be pneumonia. They get hypoxic. Can be cerebral vascular disease where they're not getting enough oxygen to the brain, and things like CHF. It can also be medication side effects. All right, so they have disturbed consciousness coupled with cognitive difficulties. So they experience sundowning syndrome. In other words, when the sun goes down, they become more confused. They can get autonomic hyperactivity where vital signs increase. They can become almost like they're paranoid, they're hypervigilant, they become labile, and they may experience any agitation or anger. All right. It develops in a rapid manner. I mean, it's acute. All right. So let's say that you go to see your grandmother this evening and you guys go out to dinner. Everything is just great. She lives alone. She's independent. She drives. You get a visitor tomorrow morning and she comes to the door and she doesn't know who you are. She's disheveled. She's unkempt. Get her to an emergency room, have them do a UA, and chances are she's going to have a UTI. All right, that's how quickly it can develop. It's very insidious. They can have illusions, they can have hallucinations. All right, four cardinal features: acute onset, inattention, disorganized thinking, and disturbances in the level of consciousness. So what are we going to do? Start with your basic nursing assessment. Check the vital signs before you do anything else. Okay. Then from there, we're going to move on to do anything that might be diagnostic. All right. Medical management, treat the underlying cause, because once you get that taken care of, it's going to go away. You can use reality orientation aids like clocks and calendars. You want to put the patient in a quiet room that's free from noise that may need to be away from the nurse's station. All right, if you need to, you may have to put the patient on a one-to-one. Reinforce reality. Make sure they have their eyeglasses and hearing aids, all right? Make sure the room is well lit, all right? Always identify yourself, speak slowly, short, simple words. One piece of information at a time, all right? Make sure they stay safe. If they're a bed climber, then put a bed alarm on them or put a sitter with them, all right? All right, so let's talk about dementia. Dementia is progressive. It is slow over a period of time, and we're not just talking about days or weeks. We're talking about months to years. These are the different types of dementias. There's our old friend Wernicke-Korsakoff. So, cognitive functioning that progressively deteriorates. No change in consciousness occurs. Okay, the majority of dementias are irreversible, but there are some reversible ones. Alzheimer's is the most common one, and that's the one we're going to focus on because the lifetime prevalence of Alzheimer's disease is up by 5% by the time individuals reach 65 and by 50% by age 85. Approximately 80% irreversible and primary. There are reversible ones, but they're due to things like brain tumors, trauma, infections. So some stats. 5.3 million people have Alzheimer's, but that's going to go up because all of us baby boomers are getting older, okay? Life expectancy is 20 years from diagnosis. That is a long time, especially if you're one of these 10.9 million unpaid caregivers, all right? So we do know that there's a possible elevation of plasma homocysteine, all right? And what we want to do is try to decrease Alzheimer's by brain stimulating activities such as those luminosity that you can get on your phone and your iPad and so forth. Leisure time physical activity during midlife and a large social network. I think that we have retirement backwards. We should be retired when we're young and we still have the energy to go do things, but we should be able to stay working during midlife and older because that's when we need the benefit of being active to help reduce any chances of Alzheimer's. So we're going to take a look at some slides. What I want you to take a look at is going to be the size of the ventricles, the area for the memory, and the area for the language. Here's what a normal brain is. Look at how nice and healthy and full those ventricles are. Look at this area, nice and full and plump. Here's an Alzheimer's brain. Look at these ventricles. Look at the wasting here. Here's a brain comparison that was done on a scan. Normal brain, look how nice and red and green it is. Look at this one. It's almost totally red with very, very little green whatsoever. Here's a normal brain scan. Again, look at those ventricles. Look at this ventricle in the Alzheimer's patient. Normal brain scan. This one was with mild cognitive impairment, and this one was with Alzheimer's disease. Huge, huge spans right there. So age is the most important risk factor. There is an early onset Alzheimer's disease, and they feel that it is inherited. Late onset doesn't have an inheritance pattern, but there's a gene on chromosome 19. It's called apolipoprotein E or ApoE, and it's identified as a risk factor. ApoE carries cholesterol in the blood and may be involved in neuronal repair. So what happens? They get cerebral atrophy, the brain shrinks. They get neurofibrillary tangles and neurotic plaques. It's not affected by ethnicity. It's an equal opportunity disease. Make sure you remember this, the 4 A's of cognitive impairment. They get amnesia, aphasia, apraxia, loss of purposeful movement. So if you put a washcloth in grandma's hand, she's going to stand there with the washcloth because she does not know what to do with it. You have to tell her what to do. Agnosia is the loss of the ability to recognize objects. An example that I use is that a home health patient I gave a nursing note to for his signature, and I gave him my ink pen. He put my ink pen down. He picked up a cough drop and he tried to sign the paper with the cough drop and held up the cough drop to me and said, "Why isn't this writing?" All right. They also do what's called confabulation. That's where they have memory impairment. They don't remember what they've done, where they've gone, what occurred, so they make up a story. That's called confabulation. Remember, that was also present in alcohol detox, where they lose their memory, so they make up a story. Perseveration, again, where they stay stuck on a topic. Okay, so primary versus secondary. Primary is irreversible. Okay, Alzheimer's secondary can be reversible, but usually it's because of things like AIDS-related dementia. It can also be Parkinson's-related dementia. All right, stages. In stage 1, which is the mild stage, they start to forget, they start to wander, and you start to see personality changes. In stage 2, or the moderate stage, confusion, hallucinations, paranoia, inability to recognize people. In stage 3, severe, that's where there's total care. All right. So I would like you guys to take a look at this YouTube, copy and paste that into your browser, and do take a look at that, please. So what do? We're going to look at the person's immediate needs. What's their level of functionings? What's the caregiver's need? Do they need some respite care so that they have time away from their caregiving duties to prevent caregiver burnout? And what community resources are available to support the caregiver? Counseling helps a lot. Health teaching, pharmacological interventions. What we want to do is avoid injury, want to improve communication, decrease agitation, look at self-care needs, prevent caregiver role strain. All right. So, oh, it cut it off. So with the medications, remember, with the elderly, start low and go slow. All right. So in 2005, the FDA issued a black box warning. Treatment of behavioral disorders in elderly patients with dementia with atypical antipsychotic medication is associated with increased mortality. Now, does that mean we can't use atypicals? No, not at all. We just need to use them in smaller doses. So there's no cure, okay? The medications that we're going to give are going to be cholinesterase inhibitors. What they do is they delay and prevent symptoms from becoming worse over a limited period of time. They're useful in treating mild to moderate Alzheimer's. They prevent the breakdown of acetylcholine, and what you can't see is that they stimulate acetylcholine in the synapse. I'll fix that for you when I post it. So the meds. Donepezil, which is known as Aricept. Originally, when donepezil was created, it was to give the patient about 2 weeks of clarity so that they could get their personal affairs into order. Rivastigmine is the Exelon patch that you see. Make sure that if you put it on, that you put it where the patient can't get to it and chew it. Put it on their back. Galantamine, Razidine, I don't see a lot of galantamine used. Memantine is also known as Namenda. It's also used alongside of Aricept. Aricept is usually used at the beginning stage to the moderate stage. In the moderate stage, oftentimes Aricept is going to be put with Namenda for the moderate stage. So this can also be used for mild to moderate stage. They can also use ergoloid mesylase, also known as Hydrogene, and it's been okayed for use in Alzheimer's disease. Another potential use of medication is insulin, which is scary to me because what if you have a caregiver who isn't paying attention to the patient and they're using insulin and the patient becomes hypoglycemic and he cannot tell the individual what he's feeling. And if they're not watching him for symptoms, it could have a tragic outcome. So the use of insulin is kind of scary, but what's interesting to me is that if insulin is that beneficial, then why is it that insulin-dependent diabetics have a higher risk for Alzheimer's? All right, so we can use medications to treat the depression. We can use SSRIs, okay, because of the low side effects. We can use things like the bupropion, venlafaxine. All right, we can use small doses of risperidone for behavior, olanzapine as well, and quetiapine. All right, none of the above medications have been approved. All right, so how do we as nurses work with an Alzheimer's client? Always identify yourself, call them by their name, speak slowly, get down to their level, short, simple words and phrases. All right, focus on one piece of information at a time. Don't argue with them. Make sure they have their glasses and hearing aid. Keep the room well lit. All right, if they get in a fight with another patient, just break them up and in a few minutes it'll subside. So that's it for lecture number 7. My gosh. Woo! Only 2 more lectures. I will get these PowerPoint slides posted for you. So I will see you on Wednesday. Bye. Thank you.